My name is Mike Campbell. Welcome to the Healthcare Fix series. This is the series number 3. We've had 2 previous, and I was looking at some of the notes. It was 20 years ago, but I'm amazed. I've got a list of all of the things that we talked about then. We could be talking about these now. I'll give you an example. Economics of the system, big topic as we spend billions and billions of dollars. Not so sure the outcomes are getting much better. We still have nurses restricted from doing certain things. What's the role of the private sector? That's still being debated. This is 20 years ago. Workers' Compensation Board, hospitals as centers of excellence to promote competition for better services. Still got a lot of work to do on that front. And personal responsibility for one's health. What can we do to save ourselves, to increase and improve our health? Well, those are the things we talked about, as I say, 20 years ago. We're still talking, but now we're going to take a look at the innovations that are available to us. What is innovation situation like in our hospital system? And for that, I've got 4 panelists. Lucky we have them. Tremendous expertise and experience within this, so let me introduce them. Joining me online right now, I have Dr. Catherine Bell. She is the president of the BC College of Family Physicians. I've got Dr. Brian Day. I can't get through his whole resume here, but I'm going to give you a hint. He's the former head of the Canadian Medical Association, past president of the Arthroscopy Association of North America. He's an honorary associate professor at University of British Columbia. Brian, welcome. I've also got Dr. Jesse Parachuk, co-director of a really interesting group. It's the Colwood Medical Clinic. We'll talk more about that, an innovative approach to healthcare, trying to reduce the wait times. I think most Canadians, or many Canadians, certainly experience what it's like to try and get a family doctor. Clinics are very busy. They're doing the best they can. You've got an innovative approach we want to talk about. Then we also have Liana Bulinchik, who's here. She is the director of Percuro. That's a really interesting firm where you're taking, really cutting edge kind of therapies out there to the public, to the patients. I loved your funding model too. We've got to talk about that. So a great group to be chatting about within this. Let me start with just a broad question. If I was to ask you what's the change from say 5 and 10 years ago, are we doing a lot more innovation or some of the same obstacles still there?
From my perspective, I see a lot of the same obstacles. Barriers would be setting up constantly. And part of our whole mandate is to help to break down those barriers to give patients better access to care.
And as I mentioned, Jesse, that you're living in an innovation.
Yeah.
You're out at Colwood, you've created your clinic. Give us a little bit about that clinic in terms of innovation.
Yeah, so one of the biggest problems that we've got right now is that we are graduating more family doctors than we ever have graduated, and yet a lot of them are choosing not to do longitudinal family practice. They're doing other things. I mean, they're Botox clinics, episodic care, there's many things, but not choosing to do longitudinal practice. And so we took a look at why that was and came up with a model that would address the reasons why family doctors were not choosing to go into the longitudinal family practice. And the biggest of those was that right now, your typical family doctor is being asked to be 2 things: a full-time family doctor and a full-time business person, but they have no training in business. Right? On top of that, just like any other small business, they don't have pension, they don't have benefits, they don't have maternity leave, they don't have sick leave. And so we decided that we would try and solve that, and ultimately ended up going about solving that problem by going to the municipalities as a way to get around a lot of the blocks to innovation that are present in the established areas.
Because they'd already have administrative expertise, we hope, as an example. But the pension thing was a huge issue when you look back to last year's federal budget, and they increased the capital gains exemption taxation part of it. And that impacted doctors' pensions around the country.
Absolutely. The impact on physicians was well publicized by the doctors of BC and by the CMA. But, on a personal level, it essentially stripped doctors of the vehicle that had been designed for us to save for retirement. And so addressing this is absolutely necessary, and really was necessary to this day to prevent doctors from looking abroad. And I'm not talking about the United States, because nobody wants to go there. Australia, Dubai, Abu Dhabi, and similar sorts of places right now are out here recruiting our doctors.
Dr. Catherine Bell, interesting that you, of course, are the president of the BC College of Family Physicians, but The question is, what are Canadians experiencing? I think most Canadians, we've got the statistics, something like 20% of Canadians don't have a family doctor. The clinics many times are overwhelmed. What is, how are we addressing that issue? Is there any innovation going on? Are we looking for respite from that?
I think one of the biggest innovations that I'm seeing in primary care is actually our family medicine-led primary care teams. And models like the Patient's Medical Home or Patient's Medical Neighborhood from the College of Family Physicians looks at how to construct a primary care team that's unique to each area, that's unique to each population, led by family medicine, but including many of the other specialties and allied health professionals operating to the full capacity of their scope. That frees up a lot of capacity and will allow us to attach a lot more patients all across Canada.
So, as a solution there, as I say, 20% of Canadians say they don't have a family doctor. Are you measuring, or will you measure the kinds of changes in that regard as we go forward?
Certainly that work of attachment is being measured across the country on an ongoing basis. And that's only one measure of really good, excellent primary care. So you can be attached to a primary care provider or attached to a family physician, but do you have access to that family physician? Do you have access to care through their team? And so the College of Family Physicians nationally just did a great survey of Canadians, and they found that the vast majority of Canadians prefer to have care from a family physician that they know, a longitudinal relationship-based primary care. And we see that that's actually the kind of care that has the highest benefits. Being attached to a family doctor lowers your chances of visiting the emergency room, lowers your chances of being unnecessarily hospitalized, even reduces our specialist colleagues' burden by reducing some of those unnecessary referrals to specialists. So investing in primary care led by family physicians is probably one of the most effective investments we can make in Canadian healthcare today.
Dr. Brian Day, in the past, one of the big challenges have been government attitudes about change, or the need for change, the acknowledgement of the change. Sometimes it happens, but they don't want to let everybody know. I mean, you've got a long experience with this, and is that the biggest obstacle you see, or is it things like we got 10 different jurisdictions provincially? I mean, there's so many other issues involved in such a major system.
Well, there are multiple problems. I see, when I came to Canada in the 70s, we were second or third in the world in the number of doctors per population. Now, according to Index Mundi, we're now in the mid to high 70s in the world rankings of doctors per population. And this was government policy. A bizarre Royal Commission in the 90s decided that the causes of rising costs were too many doctors and too many nurses treating patients. So they closed all the nursing schools affiliated with hospitals. Many of them were closed. Medical schools were cut back by intake by up to 30% across the country. Immigrant doctors and doctors on visas were not allowed to stay. And these policies have led to a doctor shortage. And of course, there's also the rationing of funding. It's a fact that most family doctors are in quotes private practice, but they don't have control over their fees in any real way. I mean, as an example, we had a problem with our door lock, and a 15-minute visit from the locksmith was $350. I could get 3 family physicians to my house for the same price. It's the market is applied to all of the family physicians' expenses, but not to their revenues and incomes. And and I say that as someone who's married to a family physician, and her sister and her brother are also family physicians. So I hear this firsthand.
Yeah, it's got me shaking my head, by the way. Dr. Pewarchuk, how did you handle that? Because you were attracting doctors to your clinic. It's a privately owned clinic.
Which one? Are you talking about the Colwood Clinic?
I'm sorry, Colwood.
Yeah, Colwood is publicly owned.
Okay.
It's owned by the city, right? The difference is that the city is acting as the proprietor here.
Okay.
But how are we attracting them? Well, first and foremost, we put together a superior deal to doing other things that are not longitudinal family practice. I think one of the things that you realize quite quickly in medical school is just how much fun it is to be that longitudinal physician. people often choose other things for practical reasons. And we wanted to take away those practical reasons or turn them on their head. And so by going about that in such a way that we take away the aspect of running your own business and dealing with those costs yourself, right, which is a huge problem. To what Dr. Day was saying, there's no doubt about it. The cost of inflation in the last 5 years has been terrifying for people in practice. It hasn't kept up with our fee increases, which have been generous, have not kept up with inflation. And so putting that on the city, who has already got the expertise on procurement, on HR, and on all of the necessary levers to keep costs low, and on top of that can borrow money at a highly preferred rate relative to a private business, it makes it much more attractive. And so our primary, aside from living in Victoria, our primary advertising point to doctors is you get to practice medicine the way you want to practice medicine. You don't have to worry about all those other things that you're not trained to do.
It's a huge challenge, Leanna. We're also talking about financing your business. How did you go about that?
Well, we felt that we've never had one penny of government funding. And we felt that with the new medications coming on, we started in 2000 and we were on the leading edge with biologic therapies. Those therapies themselves were game changers, especially in chronic disease such as rheumatoid arthritis, Crohn's disease. They moved on as their indications increased. But they were worth an awful lot of money. And as a result, we felt that pharmaceutical companies needed to have a social conscience and to assist in helping us to get those treatments to patients. Of course, too, there was a lot of concern around those medications at the time. There was some fear about their safety and should they be infused in a hospital. And we were dispelling that myth that those therapies are in fact not dangerous, that as long as you have skilled professionals looking after people, that they are very safe when administered there. So when we went to the pharmaceutical companies, they wound up funding us to be able to pay nurses to infuse them. They helped us to do the paperwork in order to procure the coverage for those patients to receive that. These treatments were funded by PharmaCare, so the patient was getting their treatment through either PharmaCare or an extended benefits plan, but who was going to infuse them? These medications, it wasn't appropriate to infuse them in the hospital because hospitals tend to be much more for ill people, and we were creating a wellness setting so that patients could come knowing that they would be cared for by trained professional nurses in a wellness setting, that they would have better access to their physicians should they need anything, because we had that relationship with the physicians that prescribed those drugs. So as a result, we did get our funding from pharmaceutical companies. We also were involved in clinical research. And so at the time, profits that came from that clinical research, we could filter a lot of that money back into our healthcare component of Procuro.
As I say, it's a fascinating model, and that's what we're talking about here, is the innovations in healthcare that can take us further. Dr. Catherine Bell, I'm just wondering about, you hear the challenge, and I hear it just anecdotally from doctors about, how do I get a 15-minute break off when every other expense has gone much higher than what I'm getting paid? Is that one of the big challenges, or maybe the major challenge, when we want to attract more family physicians to practice?
Actually, I think one of the biggest challenges from our perspective, from our members, and the BC College of Family Physicians represent 7,000 family doctors across the province. About 3/4, 75%, tell us that it's really the administrative burdens. It's the non-medicine work that we're doing every day. That's probably the biggest barrier to providing good, excellent care in our offices and in our settings. And so we know that 20 to 30% of our time translates to administrative work, and that can be essential, checking charts, checking results. But about half of that work is also unnecessary. Filling in forms, duplicate forms is probably one of the biggest chunks of time, and one that I know many of our medical association partners are working on. And we've had some great success recently with the BC government committing to pass legislation looking at banning sick notes for short-term illnesses from employers. And I think that's a small win, but it's an important win as we recognize that burden that extra paperwork puts on family physicians. And it's significant because it translates. If we were able to minimize paperwork even by 10%, we would have another probably 5.5 million visits across the country that we could open up for family medicine doctors to see their patients.
But it worries me that would seem like an obvious thing to do, an easy thing to do, and yet the progress seems to be small. I mean, if we had talked 5 years ago, you would have been able to tell me the same thing. I've been hearing that from just anecdotally from people I know in the doctors, that this is just a nightmare when you spend, as you just said, upwards of 30% of your time filling out forms, and some of them are not worthwhile. I'm hoping maybe the digitization of our healthcare records may help, but it doesn't get over the fact that we're doing things that we just don't need to be doing.
I think that speaks to some of the innovations we're seeing day to day in practice as well. And I think the introduction of AI scribes has been really important for family medicine. And we're being able to use that as a tool in your office and really reduce the amount of paperwork, transcribing, even completing some of the requisition forms that we have. That's been one innovation we've really seen, even just over the last 5 years or so, made a big difference in the amount of time we're spending doing that necessary, important paperwork, but also freeing up time to see more patients in your day.
Brian, when you've been through the system yourself, have you found the administration, the people who are making these ultimate decisions, open to innovation, open to change?
No. I mean, as you alluded to, Michael, you could almost replay the previous two healthcare fixes program, because nothing has changed. I think until people start broadening their outlook and the way they perceive healthcare, I often use this sports analogy that we're one of the worst performing health systems in the world if you look at how much we spend, according to the Commonwealth Fund and others. And I think that what you need to do is look at the top performing 3 or 4 countries and learn from what they do differently. And two of the things that, and this is not necessarily about family practice, but two of the initiatives that will improve the public system are in terms of getting access to hospital care, would be to end the global budget, the block funding of hospitals, whereby every patient, even emergency patients, are a cost to the hospital's budget, and have the money follow the patient. And then the second thing that other countries do is have a healthcare guarantee, so that people with cancer or people with even people in pain do not wait on long wait lists while they deteriorate. And one of the things I used to say as CMA president was, it's actually cheaper in the long term to treat people quickly and to treat them well, because patients who are denied access to care in any form tend to get worse, and the worse they get, the more it costs. And we have data to prove that keeping people waiting costs more than treating them quickly. The problem now is Canada has let the wait list become so massive that there will be an initial massive cost in getting rid of the backlog. And one of the big problems we have with the way the system is run is governments tend to think in 3 to 4 year terms of their office. That we need to think 15, 20 years down the road, and what we're doing now is just rationing access, cutting off access, and we definitely don't have enough doctors, and that's a big problem that you can't expect. You can't expect this massively increased population of elderly patients. The baby boomers, we have one of the highest percentage of baby boomers in the world, and we're hitting the health system like it's never been hit before. And nowadays, doctors can do a lot more than they did 20, 30 years ago. So there are problems to solve, and there is going to be an initial cost, but it's worth it because in the long term it will save money. The problem is governments do not want to make another government 30, 20 years from now look good.
You know, I spent a ton of time on economics, and economics is ultimately going to be the study of incentives. And I worry when I hear about these 15-minute chunks and not being paid very much. What incentive is there to treat a patient when patient number 62 on the end of a week, it's a long weekend, you know, you're taking time away from your family, and you go, and I'm not really getting paid for it. I'm just saying, sitting from the outside, I see that as a problem. When we go forward. And you hear that. I mean, what's the message we hear is I can't get in to see my family doctor. So again, I'd love to hear the innovations to sort of do something about that. Do you feel that same pressure, Jesse, when you're at the Colwood Clinic, for example?
Well, you know, outside of just the Colwood Clinic, to speak to that whole bit about, you know, the 63rd patient, well, it'd be more like the 163rd patient, but I was chief of medicine at the hospitals when the federal government brought in the very substantial federal income tax increase after the 2015 election, which put the marginal tax rate above 50%.
Yes.
The next time we drew up schedules, nobody wanted to work full time because people looked at it and they said, I'm getting less than 50% of that last dollar. Why would I even earn the last dollar? And so ever since then, we've had this huge problem of doctors just walking away from Friday.
Yeah.
How many doctors' offices are closed on Fridays, right? Nobody wants to work the 5-day week because they're getting 46 cents on the dollar, right? On that last dollar. And again, you know, like this, people might say, well, that's just problems that people that you know that can afford to have those problems have. But the reality is that is economics in your view. And it is reality. I watched it happen in real time. We went from having a fully staffed call schedule to having a staffing crisis, and it was entirely because of that tax change.
Yeah, and again, I don't think the politicians have been sensitive to that, you know, within that. I'm also wondering, though, the attitude of the government toward the work that you guys do, Leanne. I mean, it's a private organization doing sort of leading edge work, and including research, you know, and obviously treatment. So,
yeah. Well, what my belief was is that nurses are a profession unto themselves.
Yeah.
They're highly underutilized, undervalued. They're well-educated, critical thinkers, and they could do so much more. So within our clinic, my whole perspective was to be a nurse-led, nurse-owned, completely controlled and staffed by nurses. So to Dr. Bell's comment about paperwork, one of the things that we wanted to do was to help physicians who were filling in BC Pharmacare forms, for example, which can be quite onerous to fill in.
Yes.
So because we knew what they were looking for and what information we had to have, we made sure that the boxes were checked, that everything was written in there. If there was an explanation required, we would put the explanation in, pass it off to the physician so that they could look at it, make sure that what they saw was what was correct, sign it, and that would be that. So we were trying to free up physicians to do what physicians do best, which is to practice medicine. And we were able to create that comprehensive care model that took patients from start to finish once their physician had seen them, diagnosed them, made a decision as to treatment, and then indicated how they wanted us to proceed. We would take care of that and loop them back into their physician when the need be. So physicians were not unduly taxed by constant phone calls or appointments from patients that possibly nursing could handle, and more often we could. We created a hepatitis C treatment clinic in 2006, which I did with one of the infectious disease specialists. Then I moved on to work with the gastroenterologists who were also treating Hep C. We established a whole protocol so that, because chronic care is a perfect arena for a nurse-led model so that they could treat these diseases and know that they were well managed. Before, hepatitis C patients were going to the bottom of the pile because there really wasn't much for them, and how were they going to look after them? And it was going to be time consuming, and they had too many other patients. So our whole idea was to remove that excess work that physicians were doing and put it back where it belongs. And nurses are much more economical, I mean, face it, than physicians are.
Well, to your point, absolutely, we are underutilizing our nurses and their immense skill set. But compared to other provinces, British Columbia is severely underutilizing the potential resource of physician's assistants. We just recently introduced them into our emergency rooms. But if we had a mechanism by which community family doctors, community nurse practitioners, which we haven't talked about at all, but is an important growing part of our system, and especially community specialists, if we had a way of deploying physician's assistants like they do in Ontario or Alberta, we could magnify the impact of each of those doctors, maybe by 10-15%.
You know, we've taken on a huge subject here, you know, and so I want to finish with like a positive. No, we don't have to finish. The reality is a reality. And when you point out something like the underutilization, you know, of nurses, and I've got a list here from 20 years ago with that as one of the number one topics. You know, there's work to be done. Let me just finish, Dr. Catherine Bell. Optimistic in 30 seconds, or they still need a lot of work to do in terms of the attitude about change?
I think I'm optimistic. We've certainly seen some positive changes in the last 5 years that have supported longitudinal family medicine. And like my colleague there in the studio said, we really do need to incentivize the type of care that we want to see. And we want to see longitudinal family medicine-based family medicine primary care. That's the biggest bang for buck and the best health benefit for our patients.
What about you, Brian? You know, you've been dealing with the healthcare bureaucracy for 40, 50 years. Do you think when there's not been enough progress, are you optimistic there will be an increase in the level of progress and the attitude toward change?
No, I'm not optimistic because I think governments are afraid of this topic, afraid of the whole subject of healthcare, and as I think they're going to they're letting the system implode, and that's not a good way to handle it. There are some provinces now that are looking at rewarding patient care, but rationing of access to healthcare is a fiscal approach of governments to healthcare in Canada, and that has to change.
Obviously much more to talk about. That's why we're going to do a second series coming up here. But my thanks to the guests. Great points that you made. Great food for thought for the public who are most interested in this subject. So let me invite you to tune in for our next episode here. So much more to talk about. I look forward to you joining us.